Hello, everyone. Warm welcome from the Australian National University. Thank you for joining us today, and wherever you may be in the world, I hope that you are keeping safe and healthy. My name is Jay, and I look after international relations and partnerships here at the ANU in the areas of sciences, health, and medicine. I'm joined today by my colleague Arthur Xu, and of course, our speaker for today, Dr. Matthew Kelly. Before we start, I would like to acknowledge the Ngunnawal and Ngambri people, who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from, and I pay my respects to their elders past and present. Many of you are joining us from various parts of Australia and from around the world, and I would also like to acknowledge the traditional owners of all those lands and pay respects to their elders past and present. Now, let me introduce our speaker for today, Dr. Matthew Kelly. Matthew is a research fellow in the Department of Global Health within the ANU Research School of Population Health. His research expertise is in the areas of epidemiology, social and cultural geography and anthropology, public health and health services, nutrition, health information systems, and mortality. Matthew has a particular expertise in Southeast Asia, and he has been conducting research on transitions in health burdens in the Asia-Pacific region for the last 10 years. Part of his research in the region has been a long-running cohort study in Thailand, which is focusing on the rapid rise of non-communicable diseases in that setting. He also has considerable experience in Indonesia, where he is working with the Indonesian Ministry of Health to build the first national registration system for mortality there. Matthew has considerable experience working with many other national and international organizations on a number of health-related projects. These include the Australian Department of Foreign Affairs and Trade, the World Health Organization, and the United Nations Population Division. We are very lucky to have Matthew give us a talk today, and without any further delay, I'll now hand over to him to tell us about health transition and some of the health challenges facing countries in the Asia-Pacific. Over to you, Matt.
Hey, thank you very much, Jay, and thank you for the lovely introduction, and thank you everyone for coming along today. I wish I could be joining you in person, but I'm very glad we could come along and join me in this Zoom webinar. So as Jay said, I am going to be talking to you today about some of the major challenges to public health in the modern world. But I'm going to start by talking a little bit about what public health and population health are. These are concepts that are not always well understood. I'm going to talk about how we measure population health, some of the main indicators we use. And then I'm going to talk about changes in the overall health of populations with a concentration on Asia, but also a global view over the last decades. And I'm going to also talk a little bit about how we are now measuring health and what the main goals are for international public health in the modern era. Lastly, I'll finish by talking a bit about one of the main challenges from my point of view in measuring public health in the global setting, which is having the data available to actually assess public health. I'll finish by talking a little bit about public health at the ANU and study options, career options. Okay, so what is public health is how we're going to start this talk. I don't know what other people understand by public health, but I like this quote from Charles Winslow, who is a leading figure in the development of the modern study of public health. And his definition of public health, developed almost a century ago, defines it as the science and art of preventing disease, prolonging life, and promoting health through the organised efforts and informed choices of societies, organisations, public and private communities, and individuals. I think this is an interesting definition because it creates the focus where I think it should be, is, and how public health differentiates itself from clinical medicine and things like that, because we're looking at health at the individual level and the community level and the society level, and the roles that all of these levels have in influencing the health of individuals. Of course, health ultimately is an individual outcome, but it's not just driven by individual choices or individual actions. The society and the national and the international levels all influence the health of individuals. The World Health Organization describes public health as aiming to provide the maximum benefit for the largest number of people, again, bringing in that larger picture of health rather than just the individual level. So some of the earliest ideas for public health were developed to address issues of sanitation, and this is still an issue today. Sanitation is an influence on health, but we know even back to 500 BC, the Greek and Roman communities were instituting sanitation measures, and the first Public Health Act in the United Kingdom was around water and sanitation. And these are really good examples of what I was mentioning in the last slide about public health being a community effort. Sanitation issues are problems that are best solved by societal level interventions rather than individual treatments. So we tend to think of these as the earliest public health measures. Coming a bit further forward in history, vaccination was also a really important early public health effort by public health scientists. Again, it's trying to reduce levels of disease across whole populations. Of course, a vaccine gets administered to an individual who then hopefully will not get sick, but the vaccine also helps to protect the whole of society by stopping people from passing on diseases and reducing the overall societal level of that particular burden. We can also look at public policy efforts as public health interventions as well. We know that tobacco smoking is one of the largest causes of disease burdens in all countries around the world and has been for some time. Efforts to stop smoking can be addressed to individual smoking cessation policies, but now tobacco policies are often looking more at the public health level and thinking if we ban smoking in public places, we ban advertising for cigarettes, for example, we raise taxes on cigarettes to make them more expensive. These policies affect the whole of society and will hopefully lead to lower levels of smoking across a whole setting rather than just trying to stop one individual from smoking. Obesity is another good example of a major health burden in the modern world, which individual-based efforts to reduce obesity have been found to be fairly ineffective in most settings. Just telling people to eat more healthily and exercise more can only have so much impact. So we try to look at public health efforts that affect the population more broadly. So examples include food labelling, again, sugar taxes and fat taxes, fat and food taxes are being used in many countries now to change, the overall balance of costs of food or to make consumers more informed and educated on what foods are healthy. These may have a bigger effect on obesity than just looking at individual level weight reduction. Physical activity is also important there, and communities that provide green spaces and parks and public exercise opportunities will have more opportunity to reduce obesity rather than just telling individuals to go to the gym more. So we see we're just talking a little bit here about individual level health versus population level health. That's what the message I'm trying to give you here. So now we're going to go back in history again a little bit and look at, tell us a bit of a story about one of the earliest epidemiological public health studies. It's very famous in epidemiology, which is that of cholera in the 1800s in London. In the 1800s, cholera was a very fatal disease. It was causing a large impact on the health of people, particularly in the cities in England. But there was not a great understanding of what was actually causing cholera. People thought it was the air, or there was a popular term at that time of miasma, which is sort of like diseases being in the air around you. But along came John Snow, often referred to as the father of modern epidemiology. He was a British physician who believed, unlike his peers, that contaminated water was to blame. So, what did he do? He collected information on all of the cholera cases in London in 1854. He collected the addresses of those who were affected by cholera, and he mapped those cases according to their addresses. And he started to notice that the deaths on the cases were not randomly distributed across the whole of London, as you would expect. If it was the air that was causing it, it would be affecting people across a whole neighbourhood. But instead, I just missed a slide there, doesn't it? So instead, he noticed that the cases were clustered in particular areas, and he identified what the common factor was in the areas that were experiencing the most number of cholera cases, and that was that they shared a particular water pump. Now, in epidemiological history, this Broad Street water pump is very famous. John Snow went down and he took the handle off that pump to stop people using the water because that was the common risk factor. All the people who collected water using that water pump were the people who were getting cholera. And so he used this evidence to convince the British government that cholera was caused by water contaminated with sewage and that an improved water supply was needed. So we can see from this, he didn't get this information from looking at individual patients. He got this information from looking at the public health data, what we would now call public health data on cholera cases in the London community. Okay, so moving on to the modern era now, a whole discipline has developed outside of clinical medicine to address public health. So this slide lists some of the roles that are vital for public health research and public health work. We of course need statistics to look at patterns of disease in society and assess where those diseases are being felt most severely. But we also need social scientists. So, I mean, in my work, anthropologists and sociologists are equally important. If we want to change individual behaviours and to change societal patterns of health behaviours, then we need to understand the social science background and the cultural determinants of these health outcomes as well. Demographers are important as well to look at how the population is affected by health trends. And health interventions, of course, cost money, and health burdens cost money. We also need health economists to help us guide public policies and to look at cost-benefit analyses of different interventions and so on. Environmental scientists measure the impact of environmental factors on health, including climate change, but also, as we talked about before, sanitation, water, air pollution, and so on. And more are listed there. Parasitologists, mathematicians, vaccinologists, and of course, in the end, policy is what we need to actually change public health trends. So this slide, I don't want to spend too much time on it, but I just like this slide because it tells us a little bit about the different levels of health research. I've talked about clinical medicine as treating individuals who are sick. Biology, of course, we're looking at the development of medicines and treatments and things. But public health, we're looking at the social side of health. So they're all interrelated, and we need clinical medicine and we need biology, but I'm talking here about the social public health side of health research. So this is a little extension of what I was saying before about the different disciplines involved in public health. Here I just want to talk about, about what we do as public health researchers. So the first aim of public health is to measure the burden of disease in the population. What are people getting sick from? What are they dying from? Then we want to know the distribution of these health states across a society, across a country. We want to look at differences between men and women, between urban and rural people, are younger people having certain health conditions that older people aren't, and then we can identify health inequalities. Once we know what the health burden is and how it's distributed in the society, then we can look at what's causing that health burden, what we call risk factors. Once we've identified the risk factors, we can identify targets for public health interventions to address those risk factors. And the last stage of the public health cycle is to assess the effectiveness of these public health interventions. So this is just a broad overview of what we do as public health researchers. So in modern public health and population health, we've developed a series of standard indicators which allow us to measure the public health status of populations, but also to compare trends over time, compare trends over time and between settings in a standardized way. So the ultimate health outcome, of course, is mortality, unfortunately. It's the one health condition that affects all of us. So we want to know what the overall rate of mortality is in the population. Then we want to look particularly at infant and child mortality and maternal mortality, because these are, of course, almost always preventable deaths. If children are dying, it's usually of an infectious disease that can be prevented. So we pay particular attention to those mortality rates, and also they are a good indicator of the quality of a health system or health services in a country. Then we want to look at mortality rates for particular diseases, and probably the most widely known public health indicator is life expectancy at birth, which is an overview indicator that gives a broad indication of health conditions over the life course, health service availability, and so on. Apart from mortality, we also want to know how healthy people are while they're alive, and we also have a range of indicators that help us measure that. We use standardized measurements that are used in most settings to allow us to compare burdens of disease. So that previous slide was talking about specific health indicators, but more recently a set of sort of holistic indicators have been developed, the most famous of which is probably the disability adjusted life year lost, which is a bit of a mouthful and not an easy concept to understand. But what it's trying to balance is the idea that some health conditions cause mortality early in life, premature mortality, which leads to years of life lost. So someone dying from an infectious disease in childhood, that's a whole lot of life years lost. But also balancing that with the fact that some conditions cause significant disability and people live with ill health for a long time without that condition necessarily leading to death. So a classic example there is lower back pain or musculoskeletal pain, which people can live with for decades, causing significant disability, but not actually causing mortality. So the disability adjusted life year lost is an indicator that tries to balance those two sort of aspects of ill health. We also have the sort of closely related health adjusted life expectancy at birth and quality adjusted life years, which try to moderate that idea of life expectancy at birth as the primary health indicator by thinking about, instead of thinking just how long people will live for, thinking how long they will live for in good health, how long they will live for with quality of life. Okay, now I'm going to move on now to the second part of my talk, which is about transitions in health and in societies. So the first of the transition theories that I want to talk about is the demographic transition. Now, this was first proposed in the 1920s by a demographer named Warren Thompson. He observed that in pre-industrial societies, population sizes were kept in somewhat of an equilibrium. As you'll see in column 1 in this little figure here, high birth rates in pre-industrial societies were balanced by high death rates. So the size of populations didn't change very much, but mortality was common and fertility was high. Moving forward in time, we talked about vaccination and sanitation improvements. As those things started to improve health, particularly for children, we see that mortality rates fall, as you can see in the second column in this diagram, and the overall population size grows because the death rate falls without birth rates falling. A little later, for various reasons, birth rates also fall, and in most high-income societies, at least in the modern era, we've reached a new equilibrium, which you can see in column 4, where we have low birth rates and low death rates and ageing populations. So you can see here, these two figures are what we call population pyramids. I'm not sure if everyone is familiar with the concept of a population pyramid, but basically each bar in the pyramid represents an age group, with males being on the left and females being on the right. And the length of that bar indicates the proportion of the population in that setting who are in that age and sex group. So the clearest picture probably we can see is the right-hand pyramid there, where for Vietnam, which was the non-shaded parts, we can see that there's a very large proportion of the population in the youngest age groups, meaning high birth rates, and relatively few people in the older age groups. In the shaded bars, we can see the UK, which is more advanced in that demographic transition, and we can see there that it's not so much a pyramid anymore, but almost a column, where low birth rates have led to a much smaller proportion of the population in the youngest age groups, and the proportion up in the top age groups is greatly expanded. This is the effect of the demographic transition. Okay, a little later, after demographic transitions were observed, a new theory emerged referred to as the epidemiological transition, which in a way is the health effects of a demographic transition. So, you know, we've said a few times that in this talk already that the first improvements in public health and reductions in mortality rates were caused by vaccination, sanitation, and reducing that infectious disease burden and reducing the number of deaths in the youngest parts of society. So reducing infant and child mortality and reducing the infectious disease rates. The impact of this is that populations age, and as populations age, the burden of mortality shifts from infectious diseases to non-communicable diseases. So now we find that 68% of all deaths worldwide are actually caused by non-communicable diseases. So this is a great shift, and 80% of these deaths are in low and middle income countries. So this epidemiological transition has not just affected the high income societies, though it affected them first, but now it's affecting everybody. The 4 most important non-communicable diseases causing this large burden are cardiovascular disease, cancer, chronic respiratory disease, and diabetes. So these 4 together account for 82% of all NCD deaths. Now we're going to talk about this in a few of the upcoming slides, but the original epidemiological transition theory proposed that population aging was what was going to lead to the increased non-communicable disease burden. But we're finding now that that's not necessarily the case, and now NCD deaths are actually occurring in younger age groups as well, so that the actual whole burden is shifting a bit younger as well. And nearly a third of NCD deaths occur in those aged less than 70 now. So this little pie graph shows the overall burden of the 3 main cause groups. In burden of disease assessments, we tend to talk about 3 main groups. The first one is communicable or infectious, maternal and perinatal and nutritional health conditions, which is the orange piece of the pie here. The blue is group 2, non-communicable diseases, and the purple slice is injury. These are the 3 main cause of death and health burden groups. And we can see that the blue slice is taking up most of the pie there. But of course, this transition has not moved evenly across all countries and all settings. If you just look at group 2 in this table, we can see, for example, that 87% of deaths in high-income countries are caused by non-communicable diseases. In lower middle-income countries, it is 63%, still the majority. And then if we look below that at the global regions, we can see in all regions of the world, NCDs, non-communicable diseases, are causing the majority of deaths, except for sub-Saharan Africa, which is currently experiencing the beginnings of the epidemiological transition, but is moving along rapidly as well. Okay, so what is driving these transitions beyond the initial reduction in child mortality that we talked about earlier as the first stage of the epidemiological transition? One of the major drivers that has been observed is changes in nutrition. So over the last 2 decades, researchers beginning with the famous Barry Popkin have developed theories of how changes occur in the diets of population in response to socio-cultural, economic and agricultural change. The main point for us here is that over a long time span, famine and malnutrition have been receding in many areas of the world, but economic development and technological change have led to substantial increases in energy availability, of food availability, and a degenerative stage of the nutrition transition has been observed. So this degenerative stage manifests in increases in consumption of fats, sugars, and highly processed low fiber foods as the prices of these foods fall. Only 3 decades ago, the degenerative stage of the nutrition transition was only observed in Western economically developed countries, starting in the US in the 1980s. In the 1990s, some research emerged revealing changing diets in lower middle income countries and the increasing availability of cheap calorie-dense foods, but hunger and malnutrition were the dominant concerns. Now, advanced nutrition transitions are affecting almost all countries, with the degenerative stage being assisted by globalized food, making energy-dense processed foods available and affordable. So there's substantial variation in the manifestations of the nutrition transitions in Asia. However, there's several key changes that are observed in most settings. The most common change is a dramatic increase in the proportion of dietary energy derived from oils and fats, replacing complex carbohydrate sources. For example, China increased annual vegetable oil consumption per capita from 1 kilo in 1963 to 11 kilos in 2003. And in middle income Asia overall, per capita consumption rose from 1.5 kilos to nearly 6 in a similar time period. The proportion of energy derived from caloric sweeteners in Asian diets has also been increasing. In the last half of the 20th century, the middle income countries of Asia increased their annual per capita refined sugar consumption from 12 to 31 kilos, and the highest income groups increased from 4 to 36 kilos. Consumption of meat, mainly pork and poultry, has also been increasing, but possibly the most important dietary change, and one which incorporates all the other changes we've described in this slide, is the increase in the consumption of processed packaged convenience foods. These foods are generally high in fat, salt and sugar, and are scientifically designed to be hyperpalatable. In China, consumption of processed foods increased from 20 kilos per capita annually in 1999 to over 80 in 2012. And in Thailand, from 60 to 110 kilos. These are big increases in only 1 decade. There's also differences though in how this processed food consumption is manifesting. In Thailand and the Philippines, soft drink consumption is particularly high and approaches high income country levels. In Malaysia and Indonesia, processed high fat foods were more problematic. So that, this is one of the major dietary challenges for the modern world, and it's well underway in Asia. But the nutrition transition does not have to have negative outcomes. Rising incomes and food availability have had substantial positive incomes on population health, and there's been a global average rise of 400 kilocalories per person per day over the last 3 decades. However, while malnutrition has been receding in Asia overall, rates of overweight and obesity are rising rapidly, especially in Southeast Asia. For example, from 1980 to 2008, I know these are not the most up-to-date figures, but the trend has continued. Overweight and obesity combined increased from 12 to nearly 40% in Thailand, up to 50% in Malaysia, and from a much lower base in Indonesia from 2 to 25%. The burden of diet-related diseases, including diabetes, cardiovascular disease, and diet-related cancers, has also risen with this increase in obesity and energy intake. And as we mentioned before, these non-communicable diseases are already causing over 60% of deaths in the region. But the health effects of the nutrition transition can be even more severe in developing countries where economic changes happen more rapidly than in European countries. So many people in Southeast Asia and Asia more broadly today were born into an environment of limited nutrition or low nutrition, reduced nutrition. Later in life, these populations have experienced a surplus of energy-dense foods, and having these two conditions in one lifetime, low nutrition to overnutrition, increases again the risk of heart disease and diabetes. These populations are particularly at risk, and this is already being found to have an influence on public health in the Asia-Pacific region, where low birth weights and child malnutrition were highly prevalent just 20 to 30 years ago. So how does this shift to chronic disease in low and middle income countries fit with the transition theories that I discussed earlier? Well, basically things are changing much more rapidly than these theories predicted, and much faster than happened previously in now high income countries. This can be partly attributed to the fact that low and middle income countries can now take advantage of medical technologies, including vaccination, that were developed as European countries went through their transitions. This means that infectious disease burdens can be reduced much more rapidly. Related to this though, chronic diseases are rising at much lower incomes than previously. But this may be partly due to this nutrition transition, for example, where diet and lifestyle changes connected with NCD risk are occurring at lower ages and at lower income levels. The speed of these transitions also means that often chronic diseases are rising before infectious disease burdens have actually fallen significantly, leading to what is referred to as a double disease burden. So this does not quite fit the transition theories proposed, which involved a sort of steady transition from one state to the other, step by step. Infectious diseases fall and chronic diseases rise. We're now seeing double burdens where all health conditions are existing at the same time. So these distinctive aspects of contemporary transitions are proving particular challenges for health policy, mostly related to the speed of the transition and the lack of a slow progression from one state to the next. So firstly, health workforces within a single generation are having to learn new skills to cope with unfamiliar health problems. The changes are happening at lower income levels, as I described earlier, which is a problem because the chronic NCDs require expensive medical treatments and long-term care, which are a problem in resource-limited settings. And finally, having the infectious disease burdens coexisting with new disease burdens is a constant challenge. Okay, so moving on to the next stage of my talk, we've talked about changes in disease burden over time and theories of health change. I'm now going to talk a bit about what are the goals and the policy aims for the coming decades in terms of international public health. Since 2015, the United Nations has established a set of sustainable development goals, which aim to improve the overall livelihoods of populations while sustaining the economy and the environment. And these sustainable development goals include a specific set of health goals. So here are the health-related sustainable development goals listed. So these are responding really to that epidemiological transition which I've been discussing, as well as addressing the residual burden of infectious diseases and the growing problems of traffic injury and environmental health risks. So there's sort of an effort here to look holistically at health and look at all the major health burdens together and develop a set of cohesive goals. So it seems like a positive set of goals. I mean, they've addressed all the major health burdens have been addressed, and countries are being encouraged to regularly report progress against these goals to the United Nations in international standardized indicators, as I discussed earlier in this talk. But the major problem, and what I'm going to talk a little bit about for the rest of my talk here, is that data collection systems and health information systems in many countries globally are not set up and are not able to report against these indicators. So the clearest picture of health and the indicator which is most able to give us a clear idea of progress in the Sustainable Development Goals and the changing health profile of a country is mortality, as we've talked about mortality quite a lot through this talk. So mortality is best measured using a universal civil registration and vital statistics system, which records all deaths with a medically certified cause of death. And this universal system, which records all deaths in a country, allows the development of public health policies, interventions, guides health research, but also helps inform progress overall in health transitions and in progress against those sustainable development goals. But in this setting where we want to be able to report the country's progress and to assess public health in countries, these vital registration systems are lacking globally. I know this map is quite small and you might not be able to see individual countries, but the countries coloured in red there are countries with poor or non-existent vital registration systems. Countries in yellow are settings with incomplete. There is a vital registration system there, but it's either collecting incomplete data or not of high quality data. So we can see, particularly in the Asian region, that almost all countries are coloured yellow or red, meaning that countries are not collecting local empirical data on their health burdens. So how are we going to report the Sustainable Development Goals without local data? The answer to date has largely been through modelling and statistical techniques, basically. So without any empirical local data, models are built based on countries that do have local data, based on assumptions around population structure and child mortality rates and all these things. But this is a problem because the data cannot be known to be accurate. And with the existence of these models, there's been a lack of motivation, I suppose, to improve local health information system data collection. So these are the main two organisations which are responsible for producing these global health estimates. The Institute for Health Metrics and Evaluation in Washington State in the US, and the World Health Organization. So now I'm going to talk a little bit about COVID-19, which of course is the major health topic over the last year and a half. I haven't really talked about it so far because I wanted to give more of a broader view of the public health context over decades, rather than specifically to talk about exactly the COVID pandemic. But in the context of this lack of local empirical data on mortality, it's been quite interesting to see how the COVID-19 pandemic has intersected with that and has had some unexpected results. So of course, government functions in a lot of countries were affected by the COVID-19 pandemic. A lot of death registration offices were closed, or people did not attend health facilities because they were scared of infections. But at the same time, COVID-19 mortality has become something that's essential for every country to measure. All countries are reporting COVID-19, almost all countries are reporting COVID-19 deaths. And so, countries that weren't reporting any mortality before, as I showed on the previous slides, now are reporting mortality from COVID at least. And there's also been more of an emphasis on looking at overall mortality, where COVID testing, say, or reliable statistics on how many people actually died of COVID-19 are not available. We still want to look at overall levels of mortality to see if these have changed over time. So positive impacts of COVID-19 on mortality data collection. We're seeing a large shift from paper forms and people attending offices to register deaths to online digital platforms, which reduces infection risk, of course, but is also having an impact on overall efficiency of systems and more easy, more simple compilation of data and so on. We're seeing greater intersectoral cooperation between the health sector in governments and other government bodies, which is positive for overall health data production. As I said previously, we're seeing reporting of mortality from settings that had never reported mortality before. And overall, in the public, community, and government, we're seeing an increased awareness of the importance of health data. We can't measure the pandemic and its trends without knowing accurately, in a timely manner, what is actually going on. Right, so final slide about COVID. We've seen nearly 4 million deaths directly related to COVID recorded so far. The number may actually be higher than that. But how does that fit into these epidemiological transitions that I've been talking about, the transition from infection to non-communicable disease? Is this a backward step in the epidemiological transition? In fact, it's a bit more complex than that, because COVID interacts with non-communicable disease burdens, right? So, firstly, we know that people of older age, of course, but also independently of age, people who are obese, people who have other non-communicable diseases, such as diabetes particularly, and cardiovascular diseases, are at more risk of the more severe outcomes from COVID-19. So we could say, in a way, that the COVID-19 pandemic has actually been worse because the epidemiological transition has happened. Societies with aging populations and with high NCD burdens, we've seen in Europe particularly and the US, have been some of those worst affected by the COVID-19 pandemic. Of course, the drivers are complex, but this is one factor. The other factor is that NCD deaths themselves may have increased because of the COVID-19 pandemic. People have delayed getting diagnosed, delayed getting screened because health systems were overloaded, or because they didn't want to attend health facilities because of fear of infection. People needing treatment for non-communicable diseases have been delayed in getting that treatment because health systems are overloaded. So, the COVID-19 pandemic has likely made the NCD burden worse in some ways as well. Okay, so this is coming towards the end of my talk here. I just wanted to conclude with a few summary points. We've covered a lot of different ground here around the origins of public health, trends in disease burdens across countries and regions, what the international goals and aims are for the next 10 years of public health. But yeah, just in summary, we know a shift is underway from infectious diseases to population aging and chronic non-communicable diseases. This is driven by urbanisation, changing diets, changing physical activity patterns, changing work. The United Nations Sustainable Development Goals are now aiming to improve health holistically, improve health in all areas. But it's very hard for us to measure progress in the SDGs because we don't have enough local data on the indicators that these SDGs are measuring. But the COVID-19 pandemic has actually improved the awareness of the need for public health data and for the need for public health overall, really. But it's having a complex effect on global mortality. So that's the end of my talk about global health transitions and public health. I'll just finish by just 2 quick slides talking about ANU and what we do in regards to public health. I know we may have some prospective students in the audience. So here's an overview of our school. We have a variety of centres there looking at different areas of health. I work in the Department of Global Health, but have also previously worked in the National Centre for Epidemiology and Population Health. We have a variety of public health educational offerings. I convene the Masters of Public Health program here at the ANU. We also have an applied epidemiology masters, which is like a field epidemiology program. And of course, we also teach PhDs and Masters of Philosophy. These are some of our research strengths in our school. In global health, we're obviously looking at all of these things in an international setting, but these are just some of our research strengths. Okay, thank you all for listening to that long talk, and I'm happy to answer any questions. We'll jump into the Q&A there, but thank you for listening.
Fantastic, thank you very much, Matt. That was an interesting talk. We already have a few questions and we are taking questions now. So we've got about, 7 to 10 minutes or so. And so please, if you haven't put your questions through, put them through the Q&A box now. But Matt, if you want to start off with those questions.
Okay, right. So this first one is asking, in my experience, are negative sort of, or positive, negative as in taxes or prohibitions, or positive as in educational advertising campaigns, policies more effective over the longer term in improving public health? And are there any differences between how impactful each kind of policy is in a developed versus a developing country? Okay, well, that's a very big question. And I think what we've seen firstly, as far as educational campaigns go, is that anything that is just relying on individuals to change their behaviours is important, but is not enough. I mean, I think the answer is that we need both, unfortunately, but we need to change. So, for example, in food, we have dietary guidelines. We have, people know what healthy food is, but when we go to the supermarket, the cheapest foods are the least healthy. You can eat a processed food diet quite cheaply, whereas eating a very healthy diet costs more. So, changing that balance to make healthy foods more affordable, as well as, educating people into what is a healthy diet, I think you need a balance of both. I'm not sure about whether each kind of policy is more impactful in a developed versus a developing country. I think that's a bit too black and white, and I can't really answer that directly. I think each developed and each developing country is different, and we need tailored responses for each country. Okay, the most acceptable definition of public health. I mean, that's a tricky one to answer, but I think the first slide that I had is one of my favourite definitions. It's not about a strict sentence that defines public health. It's just that public health is addressing the multiple levels of influence on an individual's health. So we're not just talking about individual clinical outcomes, we're talking about how your community influences your health, how your society in a larger scale influences your health, and how the international environment influences your health. So that, it's not an easy definition to put in a sentence, but that's how I think about it. So thank you to Ibrahim Nigeria. Okay, Hayal. We know that the nutrition transition plays a vital role in changing the mortality rates with individuals suffering from NCDs. Despite consistently talking about how diet plays an important role in reducing mortality rates in terms of NCDs, what do you think is a major factor that is preventing that change to be seriously implemented? Okay, well, I think this is, one of those things where we talk about, I've talked a bit today about levels of influence. The global food industry can produce most cheaply these energy dense foods. They're most easily stored, they're easily transported, they're easily stored in supermarkets. So I think the major factor preventing the change is that the food industry has a lot of influence in how we develop nutrition policies and how we communicate those policies, and obviously with things like a sugar tax vigorously rejected by the food industry, and we, the food industry is a major part of our economy. So I think that's a large thing. But also at the total other end of it, even when we know what a healthy diet is, we still need convenience in our lives. We're all busy, we're all working, we need to have food that's easy as well, and that's a major problem as well. The convenience foods are the least healthy. So your last sentence, accessibility is a factor, of course. In some settings where healthy food is not available at all, but that's a different factor. Yeah. Okay. While these transitions affect health, economic transition like embracing globalization is overarching to demo, epi, and nutrition transitions. Yeah, so globalization, is correct. And the food trade globally as well. Yeah, that's one of the overarching factors driving all of these transitions. Yes, globalization spreads. You develop a new vaccine, and hopefully it can spread globally as well. But a negative health impact can spread globally. There's good and bad sides to globalization, but it's definitely one of the drivers of all of these transitions, yes. Okay, so if governments are well aware of high health and societal costs of energy-dense processed foods, why are they not acting to address this by imposing additional taxes? Okay, well, I think I answered this question previously. It's partly about it's complex. It's the food industry and their influence and their economic importance, of course. I mean, in a lot of countries in the region, Thailand's the country I know best. Thailand has a huge food processing industry itself. The Thai government trying to introduce policies, to reduce consumption of those sorts of foods will affect their own economy as well. So that's one. There's also, a bit of it's a thing in Australia we call the nanny state. I'm not sure if that's internationally translatable, but the idea that government shouldn't be telling people what they should do. People should make individual choices. It's my money, I'm going to spend it on the food I want to spend it on. There's that sort of feeling as well that governments don't want to impose too much on populations. And of course that depends on the government of the day in the particular country, what their priorities are and where they want to put them. So I hope that helps answer that question. Okay, next. So I'm going through these quite quickly because we've got a few. You can email me if you have more detailed questions or want to discuss more in detail. Okay, so unprocessed or low processed foods, such as fresh fruits and vegetables, are generally more expensive than processed foods in most developing countries, which reinforces their consumption, even more so by populations in the lower socioeconomic strata. How could this be addressed? So, yeah, I mean, at the moment, most policies are going towards taxing the unhealthy foods rather than subsidising the nutritional foods. But actually, there's quite a bit of research at the moment going on into food retailing itself. So the sort of traditional fresh markets that have existed, forever in Southeast Asia and Asia more broadly, they tend to be sources of healthy foods mainly, and they're often selling those fresh foods cheaper than supermarkets do. So for the lower socioeconomic status people, fresh markets are the best source to get healthy, cheaper food. So, in a way, not just subsidizing foods, but trying to control a bit more the food retail mix in some of these settings would also be helpful. Subsidizing fresh markets to help them not be, sort of driven out by the supermarkets and modern food retailers. That's a strategy that hasn't been tried really anywhere, but is being talked about, I suppose. How are the fields of health psychology and public health related? So psychology is a discipline in itself, as clinical medicine is a discipline in itself. So I suppose looking at psychology in public health terms is looking at the distribution of psychological states and their drivers and their risk factors across populations, rather than looking at individual, counselling or treatment measures. You would be looking at the sort of, I guess, the epidemiology of psychology in a way. So yeah, there is a public health aspect to psychology, definitely, but there's also largely a clinical aspect that treats the individual. Okay, right. Could you please share what kinds of information or data you are capturing in your mortality information project in Indonesia? Does it include things like NCDs that the person may have had but not directly linked to cause of death? Okay, this is a bit of a complex one. So in my Indonesian project, in a sample of sub-districts across the whole country, we were trying to register every death with a cause. So it wasn't aimed particularly at NCDs or infectious diseases, it's recording all deaths. When we record cause of death, ideally we have a death certificate which lists multiple causes. So the person died directly of respiratory failure. This was caused by respiratory disease, which was, preceded by, some other, even diabetes or cardiovascular disease or other NCDs that are in sort of the causal train there. So yes, if we do multiple cause of death analysis with these Indonesian data, yes, we will be able to look at the contribution NCDs made to death by looking at those multiple causes. But yeah, not directly aimed at looking at NCDs, that project, but overall death. I'm okay to stay for another few minutes, Jay, if you are. Let's go three more questions. Okay, how to improve geriatric access to primary healthcare as there is much inequality in middle-income countries? Yeah, this is, again, this is a pretty big question that I can't really answer easily here, but it's largely around government prioritising, I suppose. As I've said a few times in this talk, health burdens and ageing has changed so rapidly in many middle-income countries in Asia that the health systems that were designed for maternal and child health care and nutrition programs and vaccination programs, this has been the primary purpose of primary health care for so long in Southeast Asia that we're now sort of shifting to giving care for complex, interrelated chronic disease burdens, which are the most common in the geriatric population. So it's about making that shift happen more quickly, but that that involves funding and government prioritising. So there's not an easy answer there, except in health workforce training and capacity building, I suppose. Next one, what is the opportunity of COVID-19 in epidemiological transition? I'm not sure exactly what you mean there, but I think in one of my last slides of talking about COVID-19, HIV was a classic example of an infectious disease that actually sort of interrupted the epidemiological transition, and people started dying of an infectious disease, particularly in Thailand and other countries in Southeast Asia, and this actually slowed down the epidemiological transition. I think with COVID-19, it's a bit different because, as I was saying, it's interacting with the transition. It's causing more complications in people who have the NCD. So I think COVID-19, I don't know if that's quite answering your question. What's the opportunity of COVID-19? I mean, apart from anything else, sorry, another opportunity, I guess, of COVID-19 is strengthening primary healthcare in middle-income Southeast Asia. You know, we strengthen that frontline primary healthcare system, you know, with well-trained, capacity-built-in workforces that will allow us to address any of the arising public health problems. And if COVID-19 strengthens that, then I suppose that is one opportunity, but I'm not sure if I answered your question. Okay, and the last one is lovely, and is thanking us from PNG and saying that you appreciated this presentation as a public health master's student. So thank you for that, and no problem. I'm glad you enjoyed it.